No questions, then we'll go to the next is initiation and monitoring of ECMO. Now most of things I already covered, so I'll just fastly go. What I want you to see some videos so that it remains in your mind. Okay. So initiation steps, as I told you, team preparation, relatives preparation, circuit preparation, patient preparation. That's important. So whenever you are initiating ECMO, divide your team into 3. One who will cannulate, and everybody should have their role. Okay. Everybody should know what is their role is. So one is cannulation team. They know their role is take a consent, speak to the family, take logistic and administrative permissions, decide about what size of cannulas, and keep vascular surgeon or cardiothoracic surgeon as a backup. Okay. Suppose you are cannulating. Okay. If you are not cannulating, surgeon is cannulating, that's a different story. But if you are cannulating, always keep some vascular surgeon because you might have some complications. So that is to be kept in backup. Circuit preparation, circuit priming, and their role is to arrange for the blood and blood products. So everybody should know there. The perfusionist or your nursing staff who is priming the circuit should arrange for the blood and blood products adequately. Okay, so that is their role. Okay, and third is most important patient management team. Especially if your ECMO started first time or new ECMOs in your, everybody goes to the ECMO circuit and everybody wants to see how the priming and everything is being done, forgetting the patients. You need to stabilize the patient, remember. So you have to, especially if the patient is prone, you have to supine the patient. Usually in ICU we practice dry lung, so we keep them hypovolemic. Now you require good flow, so you have to give some volumes. You have to titrate the inotropes. So all that thing has to be done to manage the patient. So team has to be divided in 3 parts. Okay. And that is what we are intending to do over here in next 3 days. Okay. We want that you should at least develop that team spirit, that you divide your team in 3 parts at the time of initiation, and at the time of management, divide your team in 2 parts. One will manage the patient, one will manage the circuit. Okay. So that is what we want that in next 3 days you learn. Okay. Ideal steps I told you. First, increase the flow. Okay. Gradually go up on the flow. Then increase the sweep. Sweep gas has to be 0.5:1 ratio. Means what? When the blood flow is 4 liters, sweep gas is 2 liters. So when you start ECMO with 1 liter, so sweep gas should be, or 1.2 liters, sweep gas has to be 500 to 600 ml. Okay. Why? The reason is, especially in VV ECMO, when the patient PCO2 is more than 60, okay, if you rapidly correct the CO2, it will give rise to sudden hypocapnia leading to neurological damage. And they can have even bleed also. So that can increase the risk of bleed. So you have to correct the CO2 level very gradually, especially if it is more than 100, 150, get it down slowly. And the recommended speed is 14 mm of Hg per hour. So if the CO2 is say 120, I don't want that CO2 to come down from 120 to 40 in just 1 hour or half an hour. I can do that. But should not be done. It should be brought down to 40 over 4 to 6 hours, not before that. Okay. So you have to always go less on sweep gas and gradually get the CO2 down, because otherwise there will be a high risk of bleeding in the brain. Okay. Set the temperature, set the alarm. Stepwise, increase the RPM to 1000 and then release the return clamp. Venous clamp, drainage clamp you remove before, after, that doesn't make a difference. Important is drainage return clamp should not be removed before the RPM is 1000. So what usually we do is, we remove the drainage clamp, increase the RPM to 1000, release the return clamp. That should be the step. Never forget to follow these steps. That is very important. Okay. The first thing you monitor is, when you initiate ECMO, is color difference. When you initiate ECMO is color difference. See the color difference. Both the colors are drainage color and return color both are separate, different, dark red and bright red. It means grossly you are right. There is no gross level problems. Okay. So always first thing we monitor is color difference, because saturation, everything will take some time to improve. What is first going to be guide you the color difference? That is most important. Come down to the rest ventilator setting for a VV ECMO, and for VV ECMO, inotropes should come down. Okay. Your job does not get over once you initiate ECMO. I always say during lectures I told you, go to rest after the ventilator goes to the rest. So when you started ECMO, it's not that you go immediately, chalo ECMO ho gaya, now residents will manage and you go. No, you have to start ECMO, let the reach your target flow, let the rest ventilator setting comes, and then you leave. Okay. Now whatever I said, there are small video clips which I am showing you. Okay. See, this is what we have connected. This is the blood prime circuit. I am connecting the flow sensors on the return line. Okay. This is the blood prime circuit. You can see. Okay. Line is clamped. You can see the RPM is 700. Your flow is 0 because the return line is clamped. Okay. So that is what is important is you increase the RPM. Now because it's a Sorin machine, 700 RPM and VV ECMO 700 RPM is enough. But otherwise, now because there are too many machines, just keep the standard 1000 at least. Okay. These are the pre-ECMO parameters. Hemodynamic pressure is stable, saturation is around 90. On ventilator settings, peak pressure 45, FI 200, okay, PEEP of 15, respirator of 30. Okay. So this is, we have just cannulated and connected the circuit. Is this clear? Okay. We'll go to the next video. Yeah. So now what we have done is we have released the clamp, the return line clamp we have released. The first thing you see is color difference. Can you see the dark red here and return line you have seen the bright red? See the color difference, the dark red and the bright red color difference. Okay, this is the dark red, this is the bright red. Okay, so that is the first thing what you have to see. The saturation will start improving, hemodynamics pressure will go up. Okay, I can discuss on why pressure will go up. Okay, ventilator setting is still same. We have not come down to rest ventilator settings. Okay. RPM is 1000, flow is 1.7. Now because this is a Sorin machine, you don't see to get to see this much with the Mackay machines, and because the pump size are small. See, sweep gas is 800, half the blood gas flow. You see the sweep gas is 800, FI2 is 100, sweep gas is 800, okay, and your flow is 1.7 liters. Okay, that is what you need to do it. Okay, is this clear? Now why the pressure goes up? Then what we are monitoring is, this is the pre-pump pressure, P1, that is minus 17. Okay, the pressure is going to be 174 by 99, 127. Why the pressure goes up? Most of the time when you initiate ECMO, the pressure, immediately there will be a transient drop in pressure, but then it will go up. The reason is because your sedation get absorbed to the circuit, so sedation effect will come down, will decrease the PEEP, ventilator settings. The ventilator settings has come down to rest ventilator settings, you have seen. So because of that, the intrathoracic volume will decrease, and you get heart get better oxygenated blood, so the pumping capacity will increase. The CO2 will start getting clear, the acidosis starting getting clear. So all that factors will contribute to the increase in the blood pressure. Okay. Now this is P1, P2, P3. See, you can have a separate monitor and separate monitoring system for that, or what we used to do is, okay, we used to connect P1 as a separate line. Instead of CVP, we connect P1 because no point in monitoring CVP when the patient is on ECMO. So we connect P1 instead of CVP line. And we have one more return line where we connect both P2 and P3 both together. And what we can do is, we can rotate the knob. Okay. So or you can connect P1, P2, P3, all three together with the help of 3 ways. Okay. And just keep P1 as a continuous monitoring, and P2 and P3 every hourly you check, and thereby you can check the delta pressures. Okay. Okay. Monitoring, again, there are two circulations which exist, native and ECMO. So you have to monitor both patient as well as circuit monitoring. Okay. So monitoring for, there are certain complications which are dreaded. Suppose your oxygenator gets blocked, your cannula gets blocked, your ECMO gets stopped completely. There are some patients which are ECMO dependent. So they may not even give you 2 minutes time. So if your monitoring is proper, you will be able to manage the patient well. Now for an example, suppose your delta pressure is rising and you are not observed that. Now suddenly after some time oxygenator fails and your oxygenator stops. Now you don't have say another circuit which is ready and primed. That is going to take time. Now suppose patient is ECMO dependent, patient is going to go to arrest. Okay, so that is where your all monitoring is going to be very important. Okay, monitoring for adequacy and safety. I am repeatedly telling you this because this is what I emphasize, that when you go from here, you should know these two words, adequate and safety. See, remember, ECMO came into existence because of these two words, adequate and safety. In ICU, we try to manage adequacy, we forget the safety. If you want saturation good, we go up on the PEEP, we go up on the peak pressures, we forget the safety. We go up on FI2, the safety is not there. Adequacy is there. You get the saturation 90, but the safety is not there. And if you try to say, no, I'll go by ultra-protective lung ventilation, your saturation is 60. So both the ways, what has to be combined, that is why the ECMO is. Okay. So adequacy and safety, I'll just skip these slides. Circuit check cannulas. So the way you examine patient from head to toe, you examine the circuit from drainage to return line or return to drainage, whichever line you want. Okay. So look from everywhere, if there is any bleeding in the cannula site, any clot, any connection, loose connection, anything. Just look at all that. Okay. Sometimes you get alarm like this, signal alarm in rotaflow 1. Okay. That means because they used to have a jelly for flow sensors. So that jelly gun once becomes dry, you used to get this. Now rotaflow 2, they are using again an ultrasonic, so you don't require this. Okay. These are the pump noise. I think there is no noise connected here, so you will not get this. But that was the sound. You can get, when you oscillate a pump, you get a spinning sound in a normal pump. So when you initiate patient on ECMO, just oscillate the pump. That you get a spinning sound. And the moment there will be some clot in the pump, you get a crackling sounds coming in between. Okay. So we'll be able to judge whether there is a clot in the, because we will not able to see the clot in the pump. So that is the way you can examine the pump. Okay. You can see oxygenator, which a torch test. You can see there are some clots in the oxygenator, venous side and arterial side. Look at the recirculation. Both the cannula become bright red. It means there is a recirculation. So look at both the tube color. Okay. Then about the circuit pressures. You can see P1, P2 and P3 circuit pressure. P1 is, as I told you, before the pump. That is usually a negative pressures. P2 is after the pump, the most positive pressure. Immediately after the pump, before the oxygenator. Again, when the blood goes to the oxygenator, the pressure drops because of the resistance. So P3 is another positive pressure, but which is less than the P2. And the P2 minus P3 is the delta pressure or the transmembrane pressure. Okay. So pre-pump pressure, ideally, pre-pump pressure is minus 20. Why minus 20? It means there is no suction effect. Minus 20 is the pressure because of the cannula. If you remember, I told you, cannula has got a minus 20 pressure. So when you decide the cannula size, it is at minus 20. So the minus 20 means the volume is good and the pressure, there is no suction effect on the blood. It is just coming by the gravity. As the pressure becomes more negative, it means there is a suction effect. What is acceptable is up to minus 70. If it has become more than minus 70, it can lead to hemolysis. And it goes furthermore, it will lead to cavitation. Okay. So the cause of negative pressure, as I told you, is the hypovolemia, number 1. Number 2, cannula is not placed properly. It is in a small vessel, or it has gone in the side branch or something. Or it might be abutting the vessel wall, so again it will have a more negative pressure because it has to suck more blood. And third is your cannula size is small. So that's why you might have a more negative pressure. Okay. If the pressure becomes more than minus 200, then it gives us to cavitation, and that can give us to air generated in the circuit. So you can have air in the circuit by itself because there is no leak, but it is generated inside because of cavitation. And it will lead us to hemolysis. Pre-oxygenator pressure is as I told you, the most positive pressure between the pump and oxygenator. Anything which increases after load is going to increase the pre-oxygenator pressure. So if your oxygenator is more resistance, you will have high P1. Suppose you are using quadrox, your P1 will be less. You are using Sorin, it's higher because delta pressure is only 150. So definitely this pressure is going to be 200, 250, isn't it? So your P1 is going to be high. So anything after the oxygenator, suppose your artery line is clamped or artery line is kink, the P1 will increase. Suppose your cannula gets ablated to the vessel wall, the P1 is going to increase. Okay. So anything which is going, P2 is going to increase. So anything which is going to increase the resistance or increase the afterload is going to increase. Now for an example, see VA ECMO and VV ECMO. In VV ECMO, vein has got less SVR. There is no SVR. In fact, there is no resistance. So the P2 is going to be less. Same patient, if you convert into VA ECMO, the P2 will increase because in the artery the SVR is there, resistance is there. So again, the P2 will increase. So anything which increases the after load is going to increase the P2 as well as P3 both. Okay. So in both the P2 and P3 will increase. Only difference is if the low afterload or resistance in the oxygenator increases, the P2 will increase because it is afterload. But for P3, it is the preload. So preload will decrease, so the P3 will decrease. Okay. So that transmembrane pressure will increase. So delta pressure will increase. So whenever suppose you P2, P3 both increases, that means there is something outside the oxygenator which is wrong, not in the oxygenator. But your P2 increases and P3 decreases. That means the delta pressure is high. It means there is something wrong with the oxygenator. Okay. The delta pressure, as I told you, whenever the delta pressure is rise, it means invariably it is a something wrong in the oxygenator. Okay. And as I told you, what is important is the trend of the delta pressure, not one value, because different oxygenators have different delta pressures. With the RPM increase, your delta pressure is also going to increase to some extent. So what is important is the trend you to observe. Suppose your delta pressure becomes more than 1.5 to 2 times. That means you have to think that oxygenator is getting clogged. Okay, that you have to remember. Then RPM and flow ratio. Okay, with the same RPM, flow can vary. With the same RPM, the flow is same. It means preload and afterload are okay. With the same RPM, flow increases. What will happen? It is directly proportional to preload and inversely proportional to the afterload. So when the preload increases, suppose you give volume. With the same RPM, the flow will, which was 3 liters, now become 3.5 liters because the preload has increased. Patient bleed, hypovolemia, the preload will decrease. The same RPM, the flow will decrease. For afterload again, if the afterload increases, for patient on VA ECMO, okay, your patient BP start improving. With the same RPM, the flow will decrease because afterload is increased, SVR is increased. Okay, suppose there is a vasodilatation. With the same afterload, the pressure will, the flow will increase with the same flow. Same RPM, the flow will increase. So anything which decrease the afterload will increase the flow. Anything which increase the afterload will decrease the flow. So it is inversely proportional. Preload is directly proportional. Okay. So this is what is important. You can see it's the same RPM. Flow which was 5.9 liters, now it is 4.6 liters. It means either there is a change in the preload or there is a change in the afterload. You have to keep that thing in mind. Now how will you differentiate that? I will come into that one. Okay, gas flow rate, I think I already covered that. You have to go very gradually on decreasing the, on increasing the sweep gas so that CO2 level can come down gradually. Okay. Now I am showing you some importance of circuit pressures. What is the importance of circuit pressures here? Okay. Look at the RPM 2400, flow is 3.1. Okay. Now this Mackay machine, this is absolutely fine. I will not get disturbed. But for a Sorin machine, I will definitely be disturbed because I have worked with all the machines, so I know. Anyway, just look at this. This is the, sorry. Yeah. This is the patient, young patient of 24 years, dengue, ARDS, put on ECMO. This is day 12 or 13 of ECMO. Okay. He was started improving, we started coming down on ECMO flow. Just keep a watch on videos, okay. These are the parameters you can see. So, when he was, you can see the pressure is more than 350. This is the pre-oxygenator pressure, which is 350. 352, you can see the one which is blue line. Okay. So, that is the pre-oxygenator pressure. You can see the RPM flow. Saturation still 9.94. He was doing well, so we were weaning off this patient from ECMO. Okay. And while weaning, we found that the delta pressure is gradually increasing. Okay. But he was remaining stable, non-efforting. See this is a post-oxygenator pressure is 53. So pre is 350, post is 53. So the delta pressure was 300. Okay. So that was a high delta pressure. we thought that we might able to come off ECMO completely and may not have to change oxygen, because again that will going to add into the cost. So we are trying to avoid change of oxygenator. That is what initial thinking was, that if we are going to come off ECMO for 1 and 2 days, and there was no other signs except for a increase in the delta pressure. There was no other sign. He was maintaining good oxygenation because his lung was also contributing. At the same time, there was no signs of hemolysis. So we said we'll just avoid it. Okay. And this is the pre-pump pressures, -4. Okay. And saturation was 93 with that flow. Okay. So he was maintaining, so we just tried to avoid change of oxygenator. But then he started developing some hemolysis. Okay. So in that case, we thought that now we have no other choice. We have to change the oxygenator. So what we have done is, we are just, now this is the step we are showing you, is change of oxygenator. No, sorry, this is just a minute. Yeah. Yeah. So you see the oxygenator is clamped. This is a pre-oxygenator line. There are 2 clamps put on this line, 2 clamp put on the other side. We are just cutting this, both the lines. This is the post-oxygenator. There are 2 clamps. So we are removing this. We have cut this. Okay. Now this is a old oxygenator which is going out now. Okay. Look at the steps. Again, this is going to be due in the afternoon today. Now this is a new oxygenator which is already primed, and we are connecting it. Okay. So see how we are connecting it. We are pouring in water. Saturation is dropped down to 86, which was 93 initially. Okay. Hemodynamically patient is stable. Now this patient, because he is improving, lung is improving, is giving you time. Otherwise the patient may not give you even 1 minute time also. Okay. So now de-airing is being done. See how we are doing de-airing. One has to constantly put saline, okay, so that there is no air that comes, and then it should get connected in this way. Again, we are going to demonstrate to you how to do this today in the evening, and tomorrow you have to do by yourself. Okay. Fine. Now yes. So saturation is 86. The circuit is clamped, so you are getting 0 flow. RPM was 2400, and that with that the flow was 3.1 liter. Now oxygenation change. Now we are releasing the clamp. Okay. See the flow. Flow is 5.9 liters with the same RPM. Okay. Because the resistance in the oxygenator has gone down, so flow is increased to 5.8, 5.9 liter, which was 3.1. Okay. So that's the difference. Okay. Because there is no resistance now. Okay. So now, but the oxygenator was primed with the saline, not with the blood. And there's a new oxygenator. Again, there will be some kind of new source reaction. The patient develops some kind of hypotension. Okay, you can see the pressure has come down to 65/36. Okay, that's the pressure which has dropped when we change the oxygen. This is what is expected, especially if it is a not blood prime and crystalloid prime. Okay, so this can happen, and again there's a new circuit, so there's a new source reaction. Okay. Now then we are giving them fluid. Okay. And with the fluids and that, within a minute the pressure has started improving. Okay, you can see. So within a minute the pressure starts improving. What they require is just to giving fluids. Okay. So with that the pressure is improved. The saturation is immediately improved the moment we change the oxygenator. So saturation has come to 95, 96, and gradually pressure is increased now. Is increasing 80, 82/46. Okay. So it is improving and is stabilized. Okay. So now we have reduced the RPM to get the flow of 3.5. Initially the flow is 3.5. We reduce the RPM to get the flow of 3.5. And you can see now we are now checking the pressures. Okay, pre-pump pressure is -8. That is P1 is -8. Hemodynamically becomes stable. Saturation is 94. Okay. Now we are switching turning the knob. So when we are turning the knob, we will see how much is the pre-oxygenator pressure now. Okay. Pre-oxygenator is the most positive pressure. So we are getting pre-oxygenator pressure. That is around 130 to 140. That's the pre-oxygenator pressure. Okay. That is 140. And now we'll switch the knob to see the post oxygenator pressure. The oxygenator what we used was the Meadows oxygenator. Okay, so you have switched the knob. In the post oxygenator pressure around 65-70. So the delta pressure is 70. So that's the new oxygenator which is used, and that's the normal delta pressure for the Meadows oxygenator. Okay. Then comes the patient monitoring. You have to look at the vitals. Now again, there are some important points. Tachycardia can be multifactorial. The moment you put the patient on ECMO, tachycardia should settle. If the tachycardia does not settle, it should disturb you. Either your support is not adequate, or your patient is hypovolemic, or in spite of giving fluids and anything, always keep in mind retroperitoneal hematoma. That is one of the complications when you put the patient on ECMO at the time of initiation. Remember, I may not say afterwards, but at the time of initiation, immediately after initiation, tachycardia does not settle, persist, flow issues, think of retroperitoneal hematoma. Always keep that in mind. Okay. Bradycardia, sometimes you get bradycardia in VV ECMO because if your flow is directed towards the SA node, you might get bradycardia, but with that bradycardia, the pressures are fine. So don't bother about that kind of bradycardia. See RR and whether it is synchronized with the ventilator, that is most important. Look at the mean pressure, that is what usually we see, but I don't say, as I told you, follow your venous saturation or tissue perfusion rather than a mean artery pressure for VV ECMO. VV ECMO, you try to maintain normal mean pressure of 70. Okay. Pulse pressure is very important in case of VA ECMO because pulse pressure will tell you how much is the native circulation and how much is the cardiac control. If the pulse pressure is less than 10, you have to think that it can be a cardiac stunning. So always keep that in mind. Maintain pulse pressure of 10 in case of VA ECMO. Okay. Temperature usually is controlled. Okay, but keep a watch on temperature because it can cause to hypothermia. If your temperature is not connected, heater is not connected, it can just to hypothermia. So we have a lot of effects with hypothermia that again I will discuss tomorrow, today in the evening. And for VV, look at SpO2. For VA, look at SpO2 or lactate levels. Okay. Again, most important is limb perfusion. That is very important. Okay. All in 4 limbs. Lab investigations. This is what we follow. We are little conservative in case of lab investigation. We don't do too much of lab investigation. There are people who are liberal and they do every 4 hourly, 6 hourly ABG, and that usually we don't do. We go more clinically because that is we feel is not required and that is going to add into the course. So we go more clinical. This is the parameters what we follow. It is there in your book. This chart is there in your book. Okay. For VA ECMO, you have to look at the Doppler. You can see it popliteal, or you can look at the dorsalis pedis. You can use your echo probe to see the flow. It is going to be a continuous flow. This is the slide I taken from Dipanjan. Okay, so you can see a continuous flow. It is not going to be your velocity, maximum velocity might be just 0.5 or something. May not be very great. Okay.